everyone, hope you're all doing good. In this video, we are going to discuss about endometrial carcinoma. See, endometrial cancer is the most common gynecological malignancy in the world. Okay? In the world. Then, it ranks 4th among the cancers that are occurring in the female. Okay? So, the first one being your breast cancer, followed by your gastrointestinal cancers like colon cancer, and then your lung cancer, followed by your endometrial cancer. Okay? And the peak incidence of endometrial cancer is usually in the age groups 55 to 70 years. Okay? And more than 90% of these tumors are seen above 50 years, and the mean age of presentation of endometrial carcinoma is 63 years. Okay? And another important point is about 90% of the endometrial cancer will be presenting with abnormal perimenopausal bleeding or a postmenopausal bleeding. Okay? Yes. So, this is about the introduction of endometrial carcinoma. And regarding the presentation, I want to stress one point that remember 90% of the endometrial carcinomas will be presenting as a postmenopausal bleeding. But when postmenopausal bleeding is presenting, there are 90% of other causes taking up rather than endometrial carcinoma. Okay, the vice versa is not, that you have to understand, right? Yes. Now, let's see what are the risk factors for getting endometrial carcinoma. Okay, so risk factors. One main concept you have to understand why this endometrial carcinomas are occurring is because of the increased estrogen exposure. Okay, because there is increased estrogen exposure. Okay, so this can happen with increased age, that is a risk factor. Then obesity is also a risk factor, especially when there is an increased hip to waist ratio. Yes, when they have diabetes, diabetes can be either type 1 diabetes or type 2 diabetes, and when she has systemic hypertension. Okay, and when she has a PCOD, okay, because in PCOD also there can be chances of unexposed estrogen that is acting on the endometrium, leading to endometrial hyperplasia, which can in turn in future it can turn into endometrial cancer. Okay, and the other risk factors that can lead to increased level of estrogen exposure include your early menarche and late menopause. Okay, then nulliparity, because in pregnancy there is no estrogen hormone action, right? It is only progesterone that is going to act during your pregnancy. But when she is nulliparous woman, there is prolonged estrogen exposure, right? Then when she takes unopposed estrogen hormonal replacement therapy, only estrogen hormonal replacement therapy. Then in some genetic syndromes also endometrial cancer is possible. Okay, so what are these syndromes? The syndrome can be Lynch syndrome, which is hereditary nonpolyposis colorectal cancer. Okay, so there is mutation in the genes MSH1 and MLH2. Okay, then remember this syndrome is most commonly causes colon cancer. Okay, then only endometrial cancer can be seen. Okay, yes, there is 60 to 70% risk of getting endometrial cancer, however, and it presents at much earlier age compared to the rest of the population. Clear? And the next syndrome we have to discuss is the Cowden syndrome. Okay, so Cowden syndrome is occurring when there is mutation in the P10 chromosome that is present on chromosome 10. Okay, and 20 to 30% of the cases of endometrial carcinoma will be occurring in case of Cowden syndrome, and endometrial carcinoma can also happen with tamoxifen therapy or physical inactivity. Okay, yes. Now, let's discuss about the endometrial cancer types. Okay, you have two types of endometrial cancer, type 1 and type 2. Okay, so the type 1 cancer constitutes about 80% of the endometrial cancer types, whereas type 2 will be constituting only 20% of the endometrial carcinoma type. Okay, and the next point is type 1 cancer is an estrogen dependent cancer, whereas type 2 cancer is not like. Okay, it is estrogen independent cancer. So type 3 cancer involves mostly women who are young. Okay, whereas here it usually occurs in women who are older. Then type 1 cancer is seen in nullipara women, whereas type 2 cancer is seen in multipara women. So estrogen exposure is high in type 1 cancer, means these women are usually, yes, obese, whereas these type 2 cancer women are lean. And then usually the differentiation of type 1 cancer is well differentiated type, and type 2 cancer are poorly differentiated. Okay, these tumors, that is type 1 tumors, are low grade tumors usually, whereas type 2 tumors are high grade tumors. That is why these tumors, that is type 1 tumors, are non-aggressive set of tumors. Okay, whereas the type 2 tumors are aggressive tumors. Okay, and finally in the histology you will be able to see endometrial adenocarcinoma in case of type 1 tumor, whereas in type 2 tumor the histology can show anything like a papillary serous carcinoma or clear cell carcinoma, like that. Okay, and the next point is usually type 1 tumors show a good prognosis, whereas type 2 tumors show a bad or poor prognosis. Okay, the combined oral contraceptive pills and smoking are said to be protective in case of type 1 tumor, whereas in type 2 tumor they are not protective. Okay, and the 11th point is the mutations that are seen in type 1 tumors include P10 mutation, KRAS mutation, your beta-catenin, or even your PIK3CA. Okay, whereas in your type 2 tumors you will be able to see P53 mutations, then P16 mutations, then BRCA mutations. Okay, and the last point is in type 1 tumors there is metastasis that is going to the lymph nodes or else the ovaries, and in type 2 tumors there is metastasis especially to the peritoneum. Clear? So this is all about the differentiation between the different types of endometrial cancer. We have two types of endometrial cancer, one is type 1 and another one is type 2. Remember, type 1 features include, this constitutes 80% of the tumors, which is estrogen dependent. It is seen in young, nulliparous and obese women. It is a well differentiated tumor and it is a low grade tumor as well, so it is a non-aggressive tumor. histology type mostly seen is endometrial adenocarcinoma, which this tumor carries good prognosis. Combined oral contraceptive pills and smoking are protective in this tumor. The mutations generally we see here are P10, KRAS, beta-catenin and PIK3CA, and the metastasis will be mostly happening to the lymph nodes and ovaries, right? Whereas in type 2 tumors, which will constitute only 20% of the set of tumors, these tumors are mostly seen in older women who are in the perimenopausal or postmenopausal age group. These women usually will be multipara or lean women, and there is no estrogen dependency in these tumors. These tumors are poorly differentiated and high-grade tumors which are usually aggressive. The histology types seen include your papillary serous carcinoma or a clear cell carcinoma, and this carries a bad prognosis. Smoking is not protective for type 2 tumors. The histology will be showing, and then P53, P16 BRCA mutations are usually seen in this thing, and the metastasis usually happens to the peritoneum. Clear? Yes. So, I hope you are clear with type 1 and type 2 tumors now. Now, let's talk about the macroscopic appearance of the tumor. Okay. So, macroscopic appearance usually shows malignant polyp or nodule, okay, and then there will be a growth in the uterine cavity. This can be a localized growth or it can be a diffuse growth as well, and this growth can extend into the cervix or else the myometrium as well. Okay. Now let's discuss about the histological grading of endometrial tumor. So there are 3 grades of endometrial carcinoma. It is grade 1, grade 2 and grade 3. Okay. Grade 1 is a well differentiated tumor. Okay. That means it has only less than 5% of the non-squamous, I am writing it as NS, it is non-squamous or non-morular solid components. Okay. And the second category is a moderately differentiated tumor which will be having 6 to 50% of the non-squamous or the non-morular solid components. Okay. And finally, it is your poorly differentiated tumor where you will be having more than 50% of the non-squamous or non-morular solid component. Clear? Right. Now, let's discuss about some of the histological subtypes of endometrial carcinoma also. Okay. So, histological subtypes of endometrial carcinoma. Okay. So, these include endometrial, yes, very good. We have discussed in type 1, right? So, it is endometrial adenocarcinoma that can have a variant with squamous differentiation. Next one, it can be a below glandular variant or secretory variant or even a ciliated variant of endometrial adenocarcinoma. Clear? Yes. The second histological type will be, it can be a mucinous carcinoma or a serous carcinoma, clear cell carcinoma, squamous cell carcinoma, mixed cell carcinoma, and even undifferentiated carcinoma. Okay? Yes. So, these are some of the histological subtypes of endometrial carcinoma. That is, it can be endometrial adenocarcinoma and various varieties we have discussed. That can be with squamous differentiation, below glandular variety, secretory variant or ciliated variant, and others include mucinous, serous, clear cell, squamous, mixed cell and undifferentiated carcinoma. Okay. Now, the next one is, we are going to discuss about the clinical features. So, we have symptoms the women can present with, which will include abnormal uterine bleeding. Okay. So, this abnormal uterine bleeding can be post-menopausal bleeding or intermenstrual bleeding also. Okay. And in some women, there can be periods of amenorrhea which will be followed by heavy menstrual bleeding. Okay. And in some people, there can be abnormal vaginal discharge as well. Okay. Yes. Now, let's discuss about the signs in endometrial carcinoma. They can have an enlarged uterus or they can present with pyometria or abdominal mass. Okay. Yes. Now, let's see how the spread of endometrial carcinoma happens. So, spread of endometrial cancer. Okay. It can be direct spread where the spread will be directly happening to the myometrium and it can even perforate the serous cord. Okay. And there can be a tumor that is present on the body of the uterus that will be spreading to the tubes and ovary and even the lower body or even the cervix. Clear? So, the adjacent structures, internal genital organs, okay, it will be spreading. And next is, in advanced stage, what happens? The growth may even invade the bowel, bladder, vaginal wall tendon. Okay. And the next one is lymphatic spread. Okay. So, lymphatic spread will be mostly happening to the para and pelvic nodes. Okay. And next is hematogenous spread. So, this will be going to the liver, lung, brain and bones. Okay, that is LLBB, right? Liver, lung, brain and bones, and in the bones especially the pelvis. Clear? And also remember, intraperitoneal exfoliation is also possible, which means it will be happening by transtubal transport of the cancer cell. Clear? Right. Now, let's discuss about the stages of endometrial cancer. So, there is a new staging of endometrial cancer which was released by FICO in 2023. Okay, I am discussing the new stage of endometrial cancer. So, stage 1 is where the cancer is confined to the uterine corpus or the ovary. In that, we have 3 sections, say 1A, 1B and 1C. Okay, so what is stage 1A? It is a disease that is limited to the endometrium, or it is usually a non-aggressive histological type. That means it is a low-grade endometrioid tumor with invasion that is less than 50% of the myometrium, that is less than half of the myometrium. And remember, there is no or there is only local lymphovascular space involvement. Okay, and here it is a good prognosis disease. Okay, what are the points you have to keep it in mind? Number one, it is confined to the uterus and the ovary. Okay, so the disease is going to be a good disease, that is, it is a good behavior disease with good prognosis, low grading, and there is no lymphovascular space invasion, and it will be involving only less than 50% of the myometrium. Okay, and in that we will be again classifying the tumor as 1A, 1A2 and 1A3 tumors. 1A1 means it is a non-aggressive histological type, that is limited to an endometrial polyp or it confined to the endometrium. Whereas 1A2 means it is a non-aggressive histological type that is involving less than half of the myometrium, but there is no or there is only focal lymphovascular space invasion. Lymphovascular space invasion means the invasion into the blood vessels, right? And 1A3 means it is a low-grade endometrioid carcinoma which is limited to the uterus or ovary. Okay, what are all the points we spoke in 1A? It is again split into 1A1, 1A2 and 1A3. That's it, right? Then 1B means it is also a non-aggressive histological type, but there is invasion of half or more than half of the myometrium, and the lymphovascular space invasion can also be either focal or absent. Okay, and 1C means it is an aggressive histological type that is confined to a polyp or it is confined to the endometrium. Clear? So this is all about stage 1. Okay. Now let's discuss stage 2. Stage 2 means from the uterus. Okay. So imagine this is the uterus. Okay. So the first stage we have discussed what is happening in the endometrium. Now what the tumor is doing is, this tumor is coming to the cervical stroma. Okay, this tumor is coming to the cervical stroma with extrauterine extension, or there is substantial lymphovascular space invasion also, that is, it is involving the blood vessels also, and or it can be an aggressive histological type with myometrial invasion. Okay, so that is again split into 2A, 2B, 2C, just like what we have seen in stage 1. Okay, so stage 2A means invasion of the cervical stroma of the non-aggressive histological type. Stage 2B means there is substantial lymphovascular space invasion of non-aggressive histological type, and stage 2C means it is aggressive histological type with any myometrial involvement. Clear? Right. And let's see stage 3. Stage 3 speaks to you about the local or regional spread of the tumor with any histological type. Okay, it will be speaking about the local or regional spread of the tumor. Okay. So, in that we have again 3A, 3B and 3C. So, 3A means the invasion of the uterine serosa, adnexa, or both will be happening simultaneously by direct metastasis. So, see the picture? Yes. So, first stage 2 we have seen, that is involving the cervical stroma, right? In stage 3 what is happening? It is involving the uterine serosa that is present. Okay, uterine serosa that is present, or it is spreading to the adnexa. Clear? So, in that again it is split into 3A, 3B, 3C. Okay, and again 3A is split into 3A1, A2, B1, B2, and 3C is split into so many things. We'll just see it and I'll explain you in a short, simple way. Okay, don't worry. So, I have told you what is 3A. 3A is when the spread is to the uterine serosa or adnexa, or to both, that is happening by direct implantation. Okay. So, 3A1 means the spread is directly to the ovary or fallopian tube. Okay. And 3A2 means involvement of the uterine subserosa or spread through the uterine serosa. Clear? So, first comes the adnexa. 3A1 is about the adnexa and 3A2 is about the spread to uterine subserosa or serosa. Clear? And then next point is 3B, that is metastasis or direct spread to the vagina. Now it is coming to the vagina. It is coming even more down. Okay, it is coming to the vagina and the associated parameter. It is crossing above beyond the serosa. Clear? So what is 3B1? 3B1 means the metastasis or direct invasion to the vagina or parametria, whereas 3B2 means the metastasis is happening to the pelvic peritoneum, even beyond that. Okay, yes. Then let's see about 3C, metastasis to the pelvic or para-aortic lymph nodes. 3C is all about the nodal involvement, pelvic or para-aortic nodal involvement, where 3C1 means metastasis to the pelvic lymph nodes, okay, and 3C2 means the metastasis to the para-aortic lymph nodes, that is up to the renal vessels. But remember, 3C2 means the metastasis is to the para-aortic lymph nodes up to the renal vessels, but pelvic lymph nodal involvement can be present or absent. Okay. Again, this 3C1 and 3C2 are divided into 3C1 1 and 3C1 2. Okay, like this, which will be mentioning about the metastasis, either a micrometastasis or a macrometastasis. Clear? Yes. So, this is all about stage 3. Now, let's see about stage 4. Okay. So, stage 4 is where there is distant spread. That's what all carcinomas tell us, right? In all carcinomas, we'll be getting the stage 4 as a distant metastasis. So, here, yeah, the adjacent structures as well as distant metastasis is coming under stage 4. So, the spread to the bladder mucosa or the intestinal mucosa or any other distant metastasis. Okay, so this is further divided into 4A, 4B and 4C. 4A means the invasion of the bladder mucosa, intestinal or bowel mucosa, and 4B means the abdominal peritoneal metastasis beyond the pelvis, and 4C means distant metastasis. Okay, distant metastasis including metastasis to any extra or intra-abdominal lymph nodes, that is above the renal vessels. Okay, so here comes the twist. You have to remember about the lymph nodes also, which will be present above the renal vessels. Those intra-abdominal lymph nodes will be coming under stage 4C. Okay, and other organs like LLBB, that is lungs, liver, brain and bones will be coming under stage 4C. Okay, so this staging is one of the new introduction and a new addition to the endometrial carcinoma update. So, you have to know this well. Clear? Right. Now, let's talk about the differential diagnosis of endometrial cancer. Okay. So, differential diagnosis. We have to know about the causes of postmenopausal bleeding first. Okay, because endometrial carcinoma, more than 90% of them are going to present with postmenopausal bleeding only, right? So, what are the causes? So, causes can be malignant causes, which can include endometrial cancer, cervical cancer, vulval cancer, and even vaginal cancer or even ovarian or fallopian tube cancer, choriocarcinoma, or even cancer in adjacent organs, okay, like urethra, bowel, bladder, etc. Okay, and some of the pre-malignant causes of postmenopausal bleeding will include, yes, very good, endometrial hyperplasia. Then benign causes of postmenopausal bleeding will include endometrial polyps or atrophy of either the vaginal mucosa or the endometrium, then endometritis as well. Okay. Then let's discuss about the iatrogenic causes as well. See, iatrogenic causes can include any unscheduled bleeding that is happening in women who is on hormone replacement therapy and women who is taking anticoagulant therapy or even It can happen in women who's on radiation therapy. So, post radiation therapy also you can get postmenopausal bleeding. Okay, and there are, yes, obviously of the causes can go undiagnosed also. Clear? Yes. Now, let's see what are the investigations we have to offer in these women. Okay, let's discuss in detail about investigations. So, the investigations which you will offer in a woman with postmenopausal bleeding whom you are suspecting endometrial cancer include endometrial biopsy, ultrasonography, or a hysteroscope. Okay. Now, let's talk about endometrial biopsy first. Okay. So, endometrial biopsy. You have to know one fact that endometrial carcinoma can be diagnosed only when it is shown on histopathological examination. Okay, histopathological examination. So, that's why biopsy is a need of the heart where you see this kind of patient. So, the various methods in which biopsy can be taken include an office aspiration biopsy or a traditional fractional curettage, and a biopsy can be taken even through a hysteroscopy. Okay. Now, let's discuss what is this office aspiration biopsy. So, office aspiration biopsy is the first step that is done in a case where you suspect endometrial carcinoma. Okay. So, this is usually done by using two instruments, namely a pipal forceps or a vibra aspirator. Okay. So, it is a pipal curette. Okay. And this is a vibra aspirator. Okay. So, this is usually done as an OPD procedure and there is no need of dilatation, and remember the diagnostic accuracy with these procedures is very high. It is about 90 to 98%. Okay. So, this is how you do endometrial biopsy using a pipal forceps. So, you will be inserting the pipals inside, and once you are able to feel the fundus of the uterus, you have to rotate the pipals so that it will be covering all the sides of the endometrial cavity, and finally you have to aspirate it. There will be a syringe like thing, you have to aspirate it, and finally you have to push the contents into a separate container. Okay. Yes, that's it. Now, the other procedures like a fractional curettage or a hysteroscopic biopsy are performed when aspiration cannot be performed with these instruments because of cervical stenosis, or the patient is non-cooperative, or when the bleeding recurs even after negative report. Okay. Yes. Now, let's discuss about the traditional fractional curettage. Okay. So, what we call this as in short? Yes, DNC, dilatation and curettage. So, here when you do this procedure, if you able to see profuse cheesy material which is dark colored and failure to grade during curating. Okay. All this will be suspicious towards malignancy. Okay. And the next one is hysteroscopy and biopsy. Okay. When you do hysteroscopy, you will be able to visualize the entire endometrium, and then you will be able to take biopsy from a selected area. Okay. So, you should know it is more sensitive because when you visualize only focal lesions in a transvaginal ultrasonogram or something, then a hysteroscopy will be helping you in visualizing the entire cavity of the uterus and able to find the other areas of change also. Okay. Now, let's discuss about the ultrasonography you can offer to these patients. Ultrasonography. Okay. So, the point you have to make it clear is, here when you suspect endometrial carcinoma in a woman, you are not going to send her directly to ultrasonogram first. You are going to take a biopsy first. Ultrasonography is discussed next to biopsy. Clear? Yes. So, ultrasonography, that can be a transvaginal sonography. It is done to assess the endometrial thickness and ovarian status, as well as we can also rule out other endometrial pathologies, like if there is a polyp or there is a collection of fluid in cavity. Okay, if there is pyometra or even extension to cervix is present or not. Okay. You have to know, if the endometrial thickness is more than or equal to 4 millimeter, then this woman is also a postmenopausal woman. Then you have to offer them a hysteroscopic biopsy. Okay. Hysteroscopy and biopsy should be offered. Okay. Suppose if the thickness is less than 4 millimeter, then the chance of carcinoma in them is less likely, and hence immediate evaluation of the endometrium is not needed. Okay. Suppose if there is bleeding, okay, again if the woman presents to you with bleeding, then you have to do biopsy irrespective of the thickness of the endometrium. Clear? Yes. Next one, for the premenopausal woman. Okay. For the premenopausal woman, the cutoff value is not determined properly, but anytime if she is having a cutoff value equal to or more than 10 millimeter, then you have to provide them further evaluation. Clear? And also know that the interpretation of characteristic findings that are seen in TBS are as follows. Okay, we are going to discuss that. So, if you have cystic endometrial changes, then these are usually suggestive of polyps. Okay. And next point, when the endometrium is homogeneously thickened, then it indicates hyperplasia. Okay. And finally, when it has a heterogeneous structural pattern, then it should be giving you an idea towards malignancy. It is suggestive of malignancy. Clear? Yes. So, always remember, sonohysterography is always an adjunct to TBS to detect endometrial pathologies like endometrial polyp. Clear? Yes. Now, let's talk about the next set of investigations we will offer, that includes your CT, MRI, PET, CT or chest X-ray, etc. Clear? Yes. So, usually these type of investigations are helpful in detecting the spread of the disease. Okay, so that means you will be able to make out the depth, okay, Okay, you will be able to make out the depth of the myometrial extension, whether there was a spread to cervix or if there is lymph node involvement, and if there is any extra pelvic spread. Clear? Yes. Now, a CT or MRI is not routinely recommended. That you have to understand. Okay, it is not routinely recommended, and a CT is usually helpful in certain higher grade disease preoperatively to assess the lymph node involvement or even to detect if any metastasis has taken place or not. Clear? Yes. The same way, you have to understand one more point. CT is superior to MRI to detect ascites, bowel or even omental metastasis. Clear? Now, let's talk about MRI. So, MRI is the best tool to detect extension to cervix has happened or not, and it can help you to distinguish between the endometrial cancer types, okay, with an extension from the primary endocervical adenocarcinoma. Okay, repeating. And an MRI can help you in differentiating between a primary endometrial cancer or an endometrial lesion that is seen as an extension of endocervical adenocarcinoma, which can be a primary. Okay, either it has arisen from the uterus itself or it has spread from the cervical adenocarcinoma. Clear? Yes. Now, MRI is also superior to CT in one way. So, MRI is superior to CT in detection of myometrial involvement. Okay. Also, you can see about the nodal enlargement, and there is no radiation hazard with MRI. Okay. Clear? Yes. Now, let's talk about PET, that is positron emission tomography combined with CT. So, this is one of the gold standard investigation for staging. Clear? Then chest X-ray is usually done to detect metastasis in advanced lung disease. Clear? So, if you get a case of postmenopausal bleeding, first you have to check for the smears. Okay, if there is a negative cervical smear, then you can be sure to rule out cervical cancer, right? Then you will go for measuring the endometrial thickness on ultrasonogram. If it is less than or equal to 4 millimeter and you have certain risk factors, like if she is a older age group woman, or there is no history of hormone replacement therapy, or there is an irregular endometrium that is seen, okay, or there is fluid in the cavity, hematometra or hematometra or pyometra, like that, then you will be going for endometrial sampling direct. Okay. Suppose if there is no risk factors like this, then probably she doesn't need an endometrial sampling and no further action will also be taken. But if bleeding occurs, okay, if there is recurrent bleeding, then you have to go for investigations. Clear? The same way, if the thickness is more than or equal to 4 millimeter, then definitely you have to offer her an endometrial sampling plus hysteroscopy as well. If there is sufficient amount of sample, then further management will depend upon the pathology. Suppose if there is insufficient amount of sample, then you have to do a hysteroscopic guidance of investigation to take sufficient amount of samples. And if this sample is going to show you endometrial atrophy, then usually you take no further action, and the action will be taken when she is presenting again with recurrent bleeding. Clear? Yes. Now let's see about the management of endometrial cancer. Okay. So management. The staging of endometrial cancer is very important. Okay. So let's see what is the procedure of surgical staging of endometrial cancer before going into the actual treatment. Okay. So we will be opening the abdomen. Okay. Abdomen is opened and you will be giving peritoneal wash. Okay. You will be giving peritoneal wash with 50 to 100 ml of sterile saline, and this will be sent for cytological examination. Okay. If ascitic fluid is present, then there is no need to give peritoneal wash using saline. Okay. Yes. Then what you have to do is, you have to do a thorough pelvic as well as intra-abdominal examination, and if you find any suspicious lesion while doing this, you have to immediately take a biopsy. Okay, so any suspicious lesion, immediately take a biopsy. Okay, then after that you will be offering her total abdominal hysterectomy and bilateral salpingo-oophorectomy. Okay, then hysterectomy specimen is taken away and the uterus will be examined under frozen section biopsy. Okay, hysterectomy specimen will be sent for frozen section biopsy. Now, depending upon the findings along with the preoperative tumor grading, okay, so depending upon these findings along with the preoperative tumor grading, you will be offering them pelvic or para-aortic dissection. Clear? Yes. And next one is, according to the stage, what you will be doing. Okay. So, stage 1, how we are going to do it. Okay. So, stage 1 can be low risk, intermediate risk or high risk. Okay. So, low risk tumors in stage 1 means they are stage 1A tumors which belong to grades 1 and 2. Intermediate risk tumors means they belong to stage 1A grade 3 or stage 1B grade 1 and grade 2. Okay. High risk tumors means they will be grade 3 tumors and They will be type 2 tumors and lymph node involvement or enlargement is present. Clear? So, this is how stage 1 tumors are divided, and you have to know that stage 1A low grade tumors, that is grade 1 tumors, can alone be given laparoscopic management as well. Okay. For rest of the tumors, you have to offer them only a laparotomy. Okay. Yes. Now, even if she is a low risk woman, you have to offer her a total extrafusal hysterectomy with bilateral salpingo-oophorectomy. Okay. When she is a intermediate risk woman, then you will offer her total extrafusal hysterectomy with bilateral salpingo-oophorectomy. You will also do lymphadenectomy or vaginal brachy. Okay. Then for high risk women, you will offer total extrafusal hysterectomy with bilateral salpingo-oophorectomy. You should also offer them lymphadenectomy and post-operative radiotherapy also. Clear? Yes. So, the next one is management of stage 2. Okay. In stage 2 people, where there is involvement of the cervix, okay, either it will be detected clinically or by MRI or USG. The options will include, number 1, you can offer them modified radical hysterectomy, that is nothing but total abdominal hysterectomy with bilateral salpingo-oophorectomy and associated removal of parametrium and paracolpos. Okay, parametrium means the tissue that is adjacent to the uterus, and paracolpos means the tissue that is adjacent to the vagina also, about 1 to 2 centimeter upper vagina, and this should be also be combined with lymphadenectomy. Okay, so these procedures will include in modified radical hysterectomy, lymphadenectomy. Okay, and the next one is you can even offer external pelvic radiation and brachytherapy along with this surgical management after 6 weeks. Clear? Yes. And management of stage 3 includes surgical resection of all metastatic disease that will be followed by external beam radiotherapy or chemotherapy. Clear? Then management of stage 4 means usually it involves only palliative management, where we'll be doing the cytoreduction for intra-abdominal spread. Okay, it is cytoreduction, and it can be followed by platinum based chemotherapy, and in case of extra-abdominal metastasis, you will offer them only chemotherapy. Okay, that is either platinum based chemotherapy, or it can even a hormonal therapy as well. Okay, so that will include supplementation of progesterone, levonorgestrel IUCD, like that. Clear? Yes. Now let me summarize what are the indications of lymphadenectomy. Okay, lymphadenectomy. See, lymphadenectomy is recommended in stages 2 and 3 disease as well as in stage 1 disease, selected cases. For example, if it is a 1A and grade 3 tumor, or 1B, grade 1, grade 2, grade 3 tumor. Clear? Yes. And para-aortic lymphadenectomy is done when there are positive pelvic nodes or there are enlarged para-aortic nodes. Okay? And according to the type of endometrial carcinoma, type 1 will be usually a high risk grade 1 endometrioid cancer, and all cases of grade 2, grade 3 and all types of type 2 endometrial cancer will need lymphadenectomy. Clear? So, lymphadenectomy is needed when it is stage 2 and stage 3, and in stage 1 when it is stage 1A grade 3 tumor, and stage 1B any grade 1, grade 2 or grade 3. And depending upon the lymph node involvement, when it is para-aortic lymph nodes, you have to see whenever there is positive pelvic nodes, you have to remove the para-aortic nodes as well. And whenever you directly see enlargement of the para-aortic nodes, you have to remove the para-aortic lymph node removal. Okay. Then according to the type of cancer, type 1 cancer when it is a high risk type, and especially when it is a grade 1 endometrioid cancer, and grade 2 and grade 3 of any other type of cancer, you have to remove the lymph nodes. And in type 2, whatever may be the type, because grade 2 itself, type 2 endometrial cancer itself for aggressive tumors. So, in these tumors, we are going to remove the tumors, right? Remove the lymph nodes. Okay. Let's discuss about hormonal therapy. See, endometrial cancer is usually a hormone responsive cancer. Okay. And the indications will include patients who are not surgical candidates, then young premenopausal women who desires fertility, and when she has recurrent diseases that will be treated with progesterone. Okay, progestogens. Okay, when she has recurrence of the endometrial cancer even after surgery. Okay. So, the drug will be giving us progesterone orally, that is your medroxyprogesterone acetate, or intramuscularly given 17 alpha hydroxyprogesterone, or your norethistierone in the form of IUCD also you can give, that is your levonorgestrel IUCD. Okay. When you combine progesterone with tamoxifen, it will improve the efficacy of progesterone. Clear? Now, let us see about the follow-up of these people. So, follow-up, lifelong follow-up is needed. Okay, you have to do it at least every 3 months for 2 years and 6 monthly for 3 years and then yearly till her life. Clear? 3 months for 2 years, 6 months for 3 years and finally lifelong. Okay. So, during this period of follow-up, you have to offer them a vaginal examination in every follow-up and you have to ask for the symptoms like bleeding or any other associated symptoms. And also you have to offer them vaginal cytology at least 6 months initially, which can be changed to annually if the reports are negative. Clear? Yes. At this point, I want to talk to you about the various syndromes we have discussed. I already discussed in type 2 cancer that even a BRCA mutation can lead to endometrial cancer. So, if she is a BRCA1 carrier, then she can develop cancer earlier, okay, when compared to the BRCA2 carriers, okay, and maximally she can develop in less than 15 years and in some cases even the development of endometrial cancer before 40 years is also seen, okay. So, for BRCA1, you will offer surgery as a preventive measure by 35 years itself or when her family is completed, okay. Then BRCA2 people, you have to offer surgery after 35 years and this can be delayed till 45 years because there is a later onset of endometrial cancer in this group. And also remember, by delaying surgery in these group doesn't prevent the occurrence of breast carcinoma, okay. Only you can prevent the endometrial carcinoma. Endometrial carcinoma cannot happen even if it is delayed till 45 years. But breast carcinoma can happen. That is clear, right? Yes. And the next one is, if suppose the patient wants to preserve her fertility, means you can offer her radical fibroectomy, okay. And for the Lynch 2 syndrome, if they are screen positive, then you have to offer them TH with BSO prophylactically by 40 years, okay. And endometrial surveillance should be done before any decision of prophylactic hysterectomy in young women who desire fertility, and this will be done by TVS plus aspiration biopsy annually starting from 35 years until you can do hysterectomy in these, okay. Now, let me discuss about the survival rates of the endometrial cancer. So, the 1-year survival rate and the 5-year survival rate for stages 1, 2, 3 and 4, okay. The 1-year survival rate for stage 1 is 99, whereas for stage 2 is 95 and for stage 3 it is 83 and for stage 4 is 47. And for 5-year survival rate, for stage 1 this is going to be 92%, whereas stage 4 it is 74% and stage 3 it is 48% and with stage 4 it becomes only 15%, okay. That is 5-year survival. So, you have to know this well. Clear? So, now what are the other methods by you can prevent endometrial cancer, okay. Other methods of prevention of endometrial cancer. First, you have to prevent obesity and PCOS. This should be managed with diet and exercise. And if she has a prolonged anovulatory cycles, then cycle should be brought about by either using an ovulation induction agent or a progesterone, cyclical progesterone. Then suppose if there is intact uterus, then always if there is intact uterus, then you have to combine estrogen therapy with at least 10 to 12 days of progesterone in a cycle, and at the time of menopause, the woman should be counseled about the risks and symptoms of endometrial cancer, and finally oral contraceptive pills are protective against endometrial cancer. Okay, so this one you have to know. Now let me discuss about some of the fertility sparing conservative options also in endometrial cancer woman. Number 1, if she is a young woman with type 1 endometrial cancer which is well differentiated, then you can offer her hormonal treatment alone without offering her a hysterectomy. So that will retain her fertility function. Okay. Second one, PCOS and chronic anovulation can lead to endometrial carcinoma. You have to know that. Okay. And the imaging should be done always to exclude the myometrial invasion and the extrauterine disease. Okay. Counseling regarding fertility and follow-up is also essential in these people. So you can offer them magistral acetate at a dose of 160 milligram orally daily, or oral or intramuscular medroxyprogesterone acetate or levonorgestrel IUCD systems. Okay. You have to be monitoring her with repeated DNC every 3 monthly intervals. Okay. And remember, live birth is possible who respond to treatment, and postpartum hysterectomy should be, and post delivery hysterectomy should be done. Okay. Post delivery you should offer her a hysterectomy. Okay. So I hope I have covered endometrial cancer in a very detailed way right from the beginning. So what is the types of endometrial cancer, what are the causes, what are the various investigations, the detailed discussion about the new FIGO classification of endometrial cancer, and also about the various management. How do you do, where is the indication of lymphadenectomy and which is the indication of hormonal therapy and all. Hope this video have been helpful for you. So until we meet in the next video, keep going, happy learning, take care and bye bye.